Hello people, in this video let us look at nasopharyngeal fibroma. To be more specific, juvenile nasopharyngeal angiofibroma. Are you able to break up these words? Juvenile, what is juvenile? Juvenile is a person who is not yet an adult, okay? Nasopharyngeal, what is nasopharynx? You can see here, this green one which they have shown, this part is nasopharynx. Then you have oropharynx and hypopharynx or laryngopharynx. The entire thing is what? Pharynx. So we are talking about the nasopharynx. So something here. So what is there here? AngioFibroma. Okay. So where is it? In people who are not yet adults. Juvenile nasopharyngeal angiofibroma. What exactly you mean by angio? Something like a vessel, blood vessel, right? So juvenile nasopharyngeal angiofibroma or JNA. This is an ENT topic which we will be looking at. Why is it ENT, guys? Pharynx, yes, throat, right? So in ENT, what and all do you read about? You read about the ear, you read about the nose and the throat. So all this will become throat, right? Even larynx we will study about. So in the nasopharynx, right, in the nasopharynx, you can have some tumors. You can have benign tumors and malignant tumors. Okay. So benign means they are not cancerous, malignant. They are not malignant. So they are benign. So here you have this angiofibroma. This is what we are looking at the moment. JNA. JNA, juvenile nasopharyngeal angiofibroma, is coming under this benign condition of the nasopharynx. And it is on the top of this list. So what does that tell you? It's the most common tumor of the nasopharynx. Let's look at it. So it is the commonest of all benign tumors of nasopharynx. So here they seem to be showing a nasopharyngeal fibroma after a transpalatal exposure. So from the palate they are going and they are seeing the nasopharyngeal angiofibroma. Okay. So what are the clinical features these people present with? So males in the age group of 10 to 20 years or 8 to 22 years, some people are saying. Basically adolescent, you can say, isn't it? And these are people who have hit puberty. So these people have a lot of testosterone. That is why you will see males having this condition. What will they have? They will have profuse recurrent spontaneous epistaxis, that is nosebleed, right? This is the most common presentation, you should know. And because of all this blood loss, they can have anemia. Okay. They can have nasal obstruction. Why? Because there is a mass there, right? You saw that mass here. There's a mass in the nasopharynx. So if there's a mass in the nasopharynx, so here, this is the nasopharynx, there's a mass here. So what will happen? They'll have nasal obstruction. These people can have hearing loss and otitis media with effusion. Why? Because there will be obstruction of eustachian tube. Do you know where the eustachian tube opens? In the nasopharynx. So in the nasopharynx, you have the opening of the eustachian tube. And from the eustachian tube is coming from the middle ear. Right? So what will happen when there is a mass growing here and the eustachian tube is blocked? There will be middle ear infection. So there will be hearing loss. So that is another clinical feature of juvenile nasopharyngeal angiofibroma. They have conductive hearing loss because middle ear, yes, and otitis media they will have with effusion. Probably that is causing conductive hearing loss. This is all because of the obstruction of eustachian tube. How's it going, people? What are we looking at? Juvenile nasopharyngeal angiofibroma. So we're looking at the clinical features. Young males, right, 8 to 22 years, they're coming with recurrent epistaxis, anemia, conductive hearing loss, nasal obstruction, hearing loss, otitis media, all this are there, okay. Then there's a mass in the nasopharynx. So this mass is this tumor is benign, you know that, it is sessile, lobulated, smooth and obstructs one or both choanae. What do you mean by sessile? It's more like directly attached, right? No, directly attached. So it doesn't have that peduncle. It's lobulated or smooth, okay, and it obstructs one or both choanae. What is choanae? Posterior nasal aperture, we are also calling it as internal nostril. So this will be your external nostril, and somewhere here they are saying internal nostril that gets obstructed because of the mass. Okay. So it is obstructing one or both choanae. What else are they saying here? It is pink or purplish in color. Consistency is firm, but digital palpation should never be done because it will bleed on touch, isn't it? So you should not touch it. You should not palpate it. Bleed on touch because it's an angiofibroma, something to do with the blood vessels. Okay, let's move on. That's why this guy is having so much of nosebleed, isn't it? Clinical features are other clinical features. Nasal bridge, broadening of nasal bridge. I think we have a photo here for that. Here they are showing the nasal bridge, isn't it? So this one they are saying will be broadened. So let's see how it will look. Look at it here. Nasal bridge is broad. See, they have shown it here. Frog shape, frog face deformity. Swelling of cheek. Here you can see swelling of cheek. And then infratemporal fossa or involvement of the second, third, fourth, sixth cranial nerves will depend on the extent of tumor. So basically, if it has grown so much, then it can involve cranial nerves, the second, the third, the fourth and the sixth. Second is what? Optic nerve. So eyes are affected. Third is what? Third is oculomotor, again related to the eye. Then you have the trochlear. And then you have the sixth one, that is abducens. Looks like most of them are affecting the eye. So these people will have proptosis, like protruding eye. Eyeball is protruding, to be more precise. Look at this frog eyeballs protruding, frog face deformity, right? So we are done with the clinical features, guys. Let's continue. Okay. So let us see. You should not do a biopsy because this will cause profuse bleeding. Just remember this. You don't do biopsy of this mass. What exactly you will order in this case? You will order a CT scan of the head with contrast enhancement, computed tomography scan. Okay, and then in this CT scan, what you can see is the anterior bowing of the posterior wall of the maxillary sinus. This is called as antral sign or the Holman-Miller sign. Let us look at this. So in these people, when you order a CT scan here, what you can see is the posterior wall of the maxillary sinus is kind of pushed forward, right? So this is called as the Holman-Miller sign or the antral sign, okay, because it is the maxillary antrum. So this is the pathognomic feature of angiofibroma. So you will order what in these people? You will order a CT scan. What will you see? Holman-Miller sign, yes, or antral sign can be called as. Then you can order MRI also. Then carotid angiography, like you can see here, you will know which blood vessel is feeding this mass because you can do embolization so that there will be less bleeding. So you can do carotid angiography. Then during this surgery, when they are trying to remove mass, they can have blood transfusion in case it is needed. They will keep blood ready. So did you get the investigations, guys? You will order CT, MRI, carotid angiography, right? All that you will do. What are they showing here? CT scans, destruction of bone and extension into pterygopalatine fossa. So it has extended the mass into the pterygopalatine fossa. Looks like the mass is here, isn't it? Now let us see why exactly this happens. They don't know why it happens, but during this time, the adolescent males, they'll have testosterone, right, increasing. So what happens? There is hamartomatous nidus of vascular tissue in the nasopharynx. What is this? Let's break up each of these words. So hamartoma is a non-cancerous tumor which will have normal tissue and cells. So nidus is more like a place of growth. So there is a hamartomatous nidus for vascular tissue. Vascular tissue is growing in this nasopharynx. Okay. All this is because of testosterone. And some people are saying these vessels will not have tunica media, so they bleed easily. So where does this mass actually arise? Guys, focus. Where does this mass actually arise? Which mass? Juvenile nasopharyngeal angiofibroma. It arises from the posterior part of nasal cavity. So remember nasal cavity, posterior part nasal cavity, okay, close to the superior margin of sphenopalatine foramen. So inside your nose behind, okay, and where? Close to the sphenopalatine foramen, okay. So read this again. It arises from the posterior part of nasal cavity close to the superior margin of the sphenopalatine foramen. From here it will start growing. Okay, from the nasal cavity, posterior part, it starts growing. So it grows into the nasal cavity. So it grows into the nasal cavity, nasopharynx, and into the pterygopalatine fossa. Let us understand this. So the tumor is here. It's growing into the nasal cavity, and it is growing into the nasopharynx, and it's also going into the pterygopalatine fossa, isn't it? Here you have the maxillary sinus, right? This one. So the posterior wall gets pushed forward. So the posterior wall gets pushed forward. Wait, not like this. Posterior wall should get pushed forward, isn't it? Because of all that angiofibroma. Laterally, it extends into pterygomaxillary fossa. This is pterygomaxillary. This was pterygopalatine fossa. Now it is saying laterally it will go into pterygomaxillary fossa, and hence the infratemporal and dense to infratemporal fossa, and then to the cheek. So laterally it will go. Laterally means, where did they say? Pterygomaxillary fossa. Where is this pterygomaxillary fossa? They are saying the pterygomaxillary fossa is behind the maxillary antrum. See, laterally it is going where? Pterygomaxillary fossa, and then to the infratemporal fossa. Where is this infratemporal fossa? Look at this. Infratemporal fossa is here. So from the nasal cavity, it's going lateral now. It's coming out from here into the infratemporal fossa, right? Lateral. That's what they have shown here. So sphenopalatine foramen, somewhere here it started. It grew into the nasal cavity, nasopharynx. Then it went to the pterygopalatine fossa. Then it went to the pterygomaxillary part. Then it went to the infratemporal fossa. So laterally, when it grows, what will happen? Swelling of cheek. That kind of makes sense now, right? Site of origin and growth also, we saw how and all it will grow. Pathology, you see, vascular, okay, so angiofibroma is made up of what? Vascular and fibrous tissue. Angiofibro, vascular and fibrous tissue. These vessels are just endothelium lined spaces with no elastic or muscle coat. That's what they were saying, that tunica media, that there is no elastic or muscle coat. So this, well, that's why it will cause severe bleeding, because they lose their ability to contract. Guys, this you have to write. This is the exact pathology. Testosterone, because of which there is going to be some hematomatous nidus of vascular nature in the nasopharynx, right? Hematomatous nidus, place of growth, that is vascular tissue in the nasopharynx. How this vascular tissue will be? These vessels are just endothelium spaces with no elastic or muscle coat. They lose the ability to contract, so there will be severe bleeding. Bleeding you cannot control by application of adrenaline. This is benign condition. Yes, you know it is a benign condition of the nasopharynx, most common. They do not have a capsule. Usually benign means you will learn it has a capsule, but this doesn't have a capsule. Okay. So that's what you have to learn. Lose the ability to contract, just endothelium, no elastic or muscle coat. All these are very specific things. Okay. Let us look at this pathology microscopy. Angiofibroma section shows multiple dilated vessels surrounded by fibrous stroma. Dilated vessels surrounded by fibrous stroma. This is more resolution, or what do you say? Yeah, 200x. So this way you can say is the gross pathology, right? And this one will be gross, and this will be microscopy. Okay, of the angiofibroma, juvenile nasopharyngeal angiofibroma. This one they're saying is actually 32-year-old male. So maybe he had it from his adolescence or what? Okay, so let us look at the extensions, and then we have to look at the treatment. Okay, so let us do one thing. Let us look at the extensions in this video, and let us continue the treatment in the next video. Okay, extensions let us look at now. Then treatment we'll look at in next video. So extensions, where and all it is going, it is benign tumor, but it is invasive and it destroys the adjoining structures. So where and all, you already know this, it will go into the nasal cavity, paranasal sinuses, Pterygomaxillary fossa, infratemporal fossa, cheek. Yes, this also we know. Then what is there here? This side. It can go into the orbit, giving proptosis, frog face deformity. That photo you saw, remember? So proptosis and frog face deformity. Then it enters through inferior orbital fissure. It destroys the apex of the orbit. Where is this inferior orbital fissure? Do you remember? Somewhere here you have the inferior orbital fissure. This place. Okay. This is your superior orbital fissure. So this angiofibroma is entering through this inferior orbital fissure and it destroys the apex of the orbit. It can enter via the superior orbital fissure also. Now then it will go to cranial cavity. How will it go? It can extend into anterior cranial fossa through a roof of ethmoids or cribriform plate. Cribriform plate, you know where, right? Nose above where you have your olfactory. So through that it will go to the anterior cranial fossa, or it can go to middle cranial fossa. So first they said anterior cranial fossa via the cribriform plate. Then middle cranial fossa, how is it entering? Through erosion of floor of middle cranial fossa. The bone itself is eroded, looks like. The floor is eroded of the middle cranial fossa. It can erode, or indirectly it can come by invading the sphenoid sinus and sella turcica. Okay, let's go back to anatomy. So indirectly, if it is going via the sphenoid sinus or the sella turcica, where is that? So here you have, they're showing below the pituitary, what you have is the sella turcica. So via that it is going to invade, and where is it going to go? This angiofibroma to the middle cranial fossa. So here they're saying in the former case, tumor lies lateral to internal carotid artery, and the latter case it may lie medial to the artery. So however it enters, there it will lie, isn't it? What do you think? Okay. Guys, so we are done with the extensions of nasopharyngeal fibroma also. This will help in your staging and all that, okay? So what is left now is just the treatment. What is left, guys? Treatment of what? Nasopharyngeal fibroma. Yes. No, say that right. Nasopharyngeal angiofibroma. Yeah. Nasopharyngeal angiofibroma. Now, treatment we have to look at. Surgical excision they will do. There are so many techniques, guys, like transpalatine plus sublabial, which is called as Sardana approach. Then endoscopic removal via the nose, right? This is very much preferred. There are a lot of other approaches. We will look at this in the next video, okay? Based on the location of this angiofibroma, they will decide the approach. All this we have to look at in the next video. So do one thing. They will do embolization before they do the surgical excision, so that there won't be much bleeding. If it is recurrent, what they will do? Radiotherapy, right? But they don't like this radiotherapy. They are saying it can risk the development of malignancy at a later age. So they don't want to actually do that. Hormonal therapy, because it is because of testosterone, they want to give some androgen blocker like flutamide, diethylstilbestrol. This diethylstilbestrol had some problem with women, right? Having some problem with the female children born, isn't it? This is not a great thing to give to women. Look at this. This is estrogen medication, non-steroidal estrogen medication. But like they have mentioned here, it was linked to rare vaginal cancer in female offspring. If the mother has taken it in the female offspring, there can be rare vaginal cancer because of diethylstilbestrol. But looks like the treatment here is that only. They want to give estrogen to combat the testosterone. Then chemotherapy like vincristine, etc. Basically, they want to arrest the growth of these tumors. Okay. So that's all, guys. In this video, we have looked at nasopharyngeal fibroma, that is juvenile nasopharyngeal angiofibroma, JNA, you can remember. This is usually, where is it arising? Here in the posterior part of the nasal cavity. It is growing into nasal cavity, nasopharynx, and also the pterygopalatine fossa. It's a benign condition of the nasopharynx. It is the commonest of benign tumors of the nasopharynx. Then you will see it in males, adolescent, 8 to 22 years. They'll have profuse recurrent epistaxis, because of which they will become anemic. They will have nasal obstruction because of this mass. They can have the obstruction of eustachian tube, which can cause conductive hearing loss and otitis media with effusion. Because of this mass, what you can see, it will be sessile, lobulated, smooth, and it obstructs one or both choanae, etc. You should not digitally palpate it because it can bleed, right? It can bleed on touch. You can remember that. Then you will not do biopsy, remember. There can be swelling of cheek. Then there can be involvement of cranial nerves also. Cranial nerves like 2nd, 3rd, 4th, and 6th, all related to the eye. Basically, the most, you will avoid biopsy, yes. Guys, we're taking a recap, okay, of what? JNA. Don't sleep off. Okay, then investigations, what will you do? CT, MRI. In CT, what will you see? Antral sign or Holman-Miller sign, which is the anterior bowing of the posterior wall of the maxillary sinus. This is pathognomic of angiofibroma. And then you can do MRI. MRI shows any soft tissue extensions present intracranially in the infratemporal fossa. Carotid angiography will show you the feeding vessels, so you can know which vessel you have to embolize so that you can reduce the bleeding during surgery. Okay, let's just read this. If the feeding is from external carotid system, they're saying you can embolize it, and then you should do the resection within 24 hours or etc. They're saying if you delay the resection of the tumor beyond 24 to 48 hours of the embolization, there can be revascularization. Okay, then you will have to keep blood ready in case there's a lot of bleeding. Anyways, you will keep blood ready. So these are showing CT. Okay, the destruction of the bone and extension into the pterygopalatine fossa. So basically, why does this happen? Testosterone will lead to hamartomatous nidus of vascular tissue in the nasopharynx. So basically, what happens here is that these vessels which are growing, they are just endothelium lined spaces. There is no elastic or muscular coat, right? So they have lost the ability to contract. These vessels lose the ability to contract, and hence there is severe bleeding. And though this is a benign condition, they do not have a capsule. Then we saw how it, from where it arises. You saw from the posterior part of the nasal cavity, right? You saw this. From here it goes into the nasal cavity, nasopharynx, into the pterygopalatine fossa. Then it can go laterally into the pterygomaxillary fossa and then to the infratemporal fossa. Okay. This is the gross and this is the microscopy, where you can see the dilated vessels surrounded by the fibrous stroma. Coming to the extensions of nasopharyngeal fibroma, we told you it goes into the nasal cavity, paranasal sinuses, pterygomaxillary fossa, infratemporal fossa. It goes, it causes in the orbit proptosis, frog face deformity. Then it enters via the inferior orbital fissure, destroys the apex of the object orbit. It can also enter via the superior orbital fissure. Then it can enter the cranial cavity. So remember, it is so dangerous. It can enter the cranial cavity. It can enter the anterior cranial fossa through the roof of the ethmoids or the cribriform plate. It can also enter the middle cranial fossa directly, because by the erosion of the floor of the middle cranial fossa. Remember, it is bone eroding, and indirectly it can go via the sphenoid sinus or the sella turcica. Okay, and if it enters one way, it will be lateral to the internal carotid artery, or it can be medial to the artery based on how it enters. Coming to treatment, you saw surgery. Excision is this treatment of choice. You have a lot of options here, like transpalatine sublabial, that is called a Sardana's approach. Then you have lateral rhinotomy with medial maxillectomy, right? A lot of techniques are there. Then you have the facial incision, deglobing approach, etc. Endoscopic removal, this is preferred. Actually, this is via the nose, right? Then you have the transmaxillary Lefort 1 approach. Maxillary swing approach, Wheels operation is there. Then infratemporal fossa approach, intracranial, extracranial approach. They're going via the cranium, right? So based on the extent, they have different approaches, which we will have to look at in detail. This is Lefort 1, isn't it? This is a fracture actually. So basically, based on the extent they are deciding, we have to look at that. So this is embolization of the angiofibroma to decrease vascularity. This is pre-embolization, and this is after embolization. So if it is recurrent, they can try a lot of things. Radiotherapy has been used, but they are saying this can lead to malignancy in later stage of life. Hormonal, they can give diethylstilbestrol, which is a non-steroidal estrogen, non-steroidal estrogen, and flutamide, an androgen blocker. Right? Chemotherapy, they are giving vincristine. You can remember one name, otherwise you can remember the others also. All these can arrest the growth. Okay. Basically, in management of recurrent tumor, what did you say? Observe, revision surgery, removal, recur. Okay. Then radiotherapy. Radiation reduces blood supply. Okay. So that's all, guys. What else? That's it about juvenile. Nasopharyngeal angiofibroma. Can you remember this and write in the exam? Juvenile nasopharyngeal angiofibroma. If possible, we'll put the treatment video. Okay. Bye-bye.